know there's been some very impactful trial data, particularly in relation to AF intervention with ablation. But you did bravely mention, Faisal, as an EP cardiologist, as a professor in EP cardiology, you still aren't in a position to tell patients there is a cure for atrial fibrillation. So if you could clarify what exactly is the role of AF ablation in the management of atrial fibrillation, and if you could also answer from a primary care perspective a really important question: which patient should we be thinking of referring to you for an assessment for an AF ablation?
Thanks for that, yes, and a very, very important questions that you asked there. So in terms of the trial data, there have been several trials that have been published that have sort of come along in the last few years that actually have been very important, and I've listed a few of them just on the slide here. So Castle AF was a catheter ablation for atrial fibrillation in patients with heart failure, and they had implanted devices in. And essentially what the study found was that these patients with heart failure who underwent an AF ablation procedure had very beneficial effects. They had mortality benefit, and this was the first time that an AF ablation cohort actually showed a mortality benefit. So that was quite an important study published just a few years ago. There were two other big studies that have been published. The Cabana trial is an American trial, a large randomized multi-center trial looking at the effect of catheter ablation versus antiarrhythmic drug therapy on a number of outcomes, including mortality, stroke, and bleeding. And the study actually found that the arm that had AF ablation, this trial didn't reach the composite primary endpoint. However, they recognized that the actual event rate was very, very low in the trial, and there were also some issues of crossover between the two arms within that study. The latest study really that's shown here at the bottom is the EAST trial, which is early rhythm control in patients with atrial fibrillation, which was published just very recently in the New England Journal of Medicine. And this study, again, a large multi-center randomized controlled trial, primarily within Europe, that looked at early intervention, be that with ablation or with drug therapy, of having an aggressive early rhythm control strategy, and found that actually there the patients did do better with that strategy. So again, evidence suggesting that rhythm control actually is important. In terms of what the guidelines say of who should be having an ablation or who should be having drugs, I think these slides can be very, very helpful for us. Again, it's interesting to note that patient choice is actually high up there, no matter what therapy we talk about. So it's important to have that discussion with the patient in front of us, assessing their risk factors. And again, risk factors are highlighted here, as well as their comorbidities, ensuring that they're on the correct therapies, ACE inhibitors, ACE receptor antagonists, and particularly treatments for hypertension or for LV systolic dysfunction. Now, patients who have no or minimal structural heart disease, antiarrhythmics can be tried. And again, we normally start with the class 1 antiarrhythmics, drugs such as flecainide or propafenone. We also have dronedarone, which is a newer class 3 drug that's used in selected patients as well. But catheter ablation is an option, again, after discussion with the patients. Those that have preserved heart pump function but have coronary disease, again, the drugs that you're kind of limited by then are drugs such as dronedarone and amiodarone. Amiodarone, of course, is the most powerful antiarrhythmic, but is associated with some quite nasty side effects both in the short and the long term, and may not be an option really. A catheter ablation also can be considered in this cohort, and those who have heart failure with reduced ejection fraction, where the LV systolic function is significantly impaired, their catheter ablation or amiodarone, and again, a close discussion with the patient about what they would prefer themselves. And again, the key thing around ablation is that discussion with the patients. We always highlight to the patients that the reason for doing an AF ablation is to improve symptoms. So you have a patient who's in AF, they feel far better in sinus rhythm than they do in AF, but keep going into AF despite medical therapy. That may be with or without amiodarone. And there, a discussion around ablation can be very important, and particularly also in younger patients who may not want to take nasty drugs such as amiodarone, or who are taking antiarrhythmics such as flecainide, but actually don't want to take flecainide longer term. And we know from the evidence that actually AF ablation can be particularly helpful in those patients. And currently we have two broad ways of performing an AF ablation. And essentially what we do know is that the pulmonary veins that drain blood from the lungs back into the top left chamber, the left atrium, have sleeves of muscle tissue within them that fire off ectopic beats, which then triggers atrial fibrillation. That was really discovered in the early to mid 90s. And an ablation procedure involves putting in either a single piece of kit, a balloon with a wire that comes out, pushed against the vein, blocking the vein, inflated up, and that then freezes the outside of the vein. And that freeze generates a scar which seals the vein electrically, so the signals cannot escape back out. The alternative is using point-by-point radiofrequency ablation, where we're burning tissue, and typically we use a 3D mapping system to do this. So we're putting two wires into the left atrium, into the top left chamber. We're seeing the signals within the pulmonary veins, and we are burning outside the pulmonary veins around them in pairs, usually, to seal them off. And that scar that's generated by the burning this time also prevents the electrical signals from getting out. And the success rate can vary, of course, between the type of atrial fibrillation. Those with paroxysmal atrial fibrillation usually have a higher success rate, in the region of 70 to 80% with one procedure at 1 year, whereas those with more persistent atrial fibrillation tend to have lower success rates, because we know that the AF can potentially come back, and we tend to quote a 50 to 60% success rate at 1 year. And some people do need to come back for more than one procedure. But again, having a very individualized discussion with them and looking at them is very, very important in talking about risks of ablation. I've just shown a slide here of a paper that we've just recently published looking at the safety and cost effectiveness of day case catheter AF ablation, which is what we've been doing in Coventry for a while, and many other authors around centers around the world have published their data as well, very much in keeping with ours, showing that this is a very safe, effective, and a cost-effective way of managing patients who have atrial fibrillation, and actually can provide a significant benefit for them. Again, when we look at the detail of some of the guidelines, it all comes down again to patient choice, and this slide tries to differentiate between those that have major, minor risk factors, and also recognizing the Castle AF trial, that those with heart failure with reduced ejection fraction, thinking about an AF ablation in those selected cohort of patients earlier. But catheter ablation, you can see, is dotted around these slides. And in terms of primary care, which is you asked about specifically, I think, again, a discussion with the patient around quality of life and symptoms and the medication they've tried. And I think early referral on, ideally, to electrophysiologists such as myself, I think is quite important, because what we do know is that the earlier we perform an AF ablation in that AF journey, the more likelihood that they will have success at 1, 2, 3 years down the line. So an early intervention is better than one that is delayed, because over time the atrium can develop an atriopathy, and then maintaining sinus rhythm can be more difficult. So really, this is a summary slide showing the AF guidelines really in a nutshell, highlighting that the patient is at the center with all the various primary and secondary care healthcare providers around them, and the guidelines very much advocating a CC to ABC approach. CC is to confirm AF with a 12-lead ECG or a single channel recording, to characterize the AF using the 4S approach that we've talked about, and then having an ABC approach of ensuring that there is anticoagulation, and we think about stroke risk, of ensuring that we control the symptoms so that patients' quality of life is considered, and rhythm control, rate control are also considered and discussed. And then thinking about comorbidities and risk factors and tackling those for each patient that's in front of us. And with that, I'll hand back to you.
What can I
So
say?
thank you.
Yeah, what can I say, Faizel? That was a masterclass overview of the current evidence, and really brought us up to speed with the current guidelines in atrial fibrillation. I think the two things that stood out for me were really, the most important stakeholder in this whole piece is the patient, and we've got to have the patient right at the center of that decision-making process. But also, if we are considering intervention, I think it's really important to remind ourselves, you reinforced it beautifully, that the earlier you intervene, the better the outcome. So if you are going to if you're thinking a patient maybe benefit from an intervention, let's get that referral done early. Before I let you go until the discussion at the end, Faizel, you mentioned that you can't cure atrial fibrillation. So what you didn't do actually was define what you mean by a successful ablation. What does success mean in terms of an AF ablation procedure?
So that's a very good question. So when I say I don't use the word cure, a cure implies that you've done the procedure and the AF will never come back again. It's gone for good, and I would say that's not that's not usually the case. And we know that as the heart ages, as I've mentioned, as the atrium dilates, the risk of atrial fibrillation coming back is there over time. Now, what we're doing by doing an AF ablation is actually minimizing that and actually maintaining normal rhythm for a lot longer. And so, in terms of success rate and how we would define success rate, we would look to make sure that the veins, the pulmonary veins, are isolated as a first off procedure. And again, in those with paroxysmal atrial fibrillation, where we know the veins are the triggers of the atrial fibrillation, if we've isolated the veins, we know the outcome's actually very good and the success rates tend to be quite high. We tend to quote here in Coventry a 70 to 80% chance of success at 1 year. And actually, for paroxysmal AF, we know the outcomes are around about that level. However, those with persistent AF, what tends to happen is that the veins, of course, are important, but then the atrium itself can become important in triggering and maintaining atrial fibrillation. And so if you're just isolating the veins themselves, you're not necessarily going to be preventing that AF from coming back if you have recurrent persistent, particularly if you have long-standing recurrent persistent, where other parts of the heart, the atrium, can become important. And we often will then, if they come back for further procedures, we'll make sure the veins are isolated because they can often reconnect over time, and that just happens within the normal heart. But we will often then do other ablations within the heart, near the roof of the heart or the back of the heart. And there are certain areas that are a little bit more difficult for us to do ablations on because they increase the risk of complications. But really, in terms of success rate, our first off procedure is to isolate the veins to make sure that they are electrically sealed and there is a good pulmonary vein isolation, or PVI, done at the very first procedure. When they come back, to ensure that the veins are isolated, and if any further ablation or burning needs to be done, we then target that.